Thank you. So we'll be discussing on the evaluation of the headache and facial pain. So headache is one of the most common symptoms for which the patients comes to a pain clinic, and it is one of the most common kind of pain as a overall also. And most diagnostic clues come from the history. That is one of the biggest difference with the headache with other disorders, because the history is the main thing which you have to go for the diagnosis, because there will always be a paucity on the clinical examination or imaging. Remember, the common headaches like a migraine, like a cluster headache, absolutely will be not finding any abnormality in any imaging scans. So that is quite common. So here history is our main guiding things. But before going to headache proper, let us see what are the structures in head that are sensitive to pain. So there are some extracranial structures, there are some intracranial structures. Among the extracranial structures, we have the scalp, which is definitely pain sensitive. We have the skin, subcutaneous tissue, scalp, periosteum. So they all having the pain sensitivity. So any disease affecting these areas can cause pain and can cause headache. Now coming to the joints like the temporomandibular joint, the cervical joints, they could be a possible cause of pain. Like a cervical, upper cervical joints, like a facet joint, they can cause a cervicogenic headache. Similarly, a temporomandibular joint arthrosis can cause a pain at this point. Okay, so sometimes you have to be very careful to differentiate it from the trigeminal neuralgia and also from the glossopharyngeal neuralgia, because the location is very close. Okay, definitely we have some clues whether it is nociceptive or neuropathic. Like that, we have some ways to differentiate it that I will be discussing today. Next comes the muscles. So the muscles of the scalp, paraspinal muscles, they could be possible source of pain in pathology, not in normal condition. So it could be possible there could be a myofascial pain affecting these muscles, and that could be a possible cause of pain. Then comes to the paranasal sinuses and ocular contents and teeth. And remember, teeth is a very important thing. Whether you are diagnosing, you should always check for the teeth as well, ask for the patient, and if required, you will be doing a dental referral as well. And remember, it happens sometimes the patient of trigeminal neuralgia coming to us with a lot of the tooth extracted, because initially there was definite diagnosis was not made, and initially it is taken mistaken as a toothache, and ultimately for which different treatment has already been undergone. Sometimes the tooth is extracted as well, so it happens quite commonly. So you should be careful not to misdiagnose the things. Next, come to the intracranial structures like arteries, veins, and venous sinuses. They are all pain sensitive. Meninges, the pia, arachnoid, and dura, they are also pain sensitive, and definitely the cranial nerves are also very pain sensitive. So these are the structures. So any lesion which is intracranial compressing on those structures can produce pain. Remember, this type of pain which is due to some intracranial disorders, that could be dangerous, and this is falls into a red flag as well. Now coming to the causes. So we'll be discussing a little bit about the ICHD-3, which is published in 2018, and that is till now it is the most common guideline. So they have divided the headache main three groups. First of all, they are the primary headache disorders. Next, the secondary headache disorders, and third, the neuropathies and facial pains and other headaches. So primary headache, what is called a primary headache? A primary headache is those disorders which is not having any underlying structural causes. Okay, so they are the primary headaches. Secondary headaches are those which is associated with some underlying structural causes. For example, a brain abscess causing pain. So that could be a secondary headache disorder, or a tumor causing pain, that could be a secondary headache disorder. Whereas the migraine, the cluster headache, chronic daily headache, or tension type headache, they are actually examples of primary headache disorders, where even with the investigation we will not find anything. Okay, there is no structural change here. And neuropathies and facial pain, they are also in most of the common cases like a trigeminal neuralgia, glossopharyngeal neuralgia, we will not be finding any such structural damage there. Okay, but still the pain is persisting and we have to treat accordingly. Now, the primary headache disorders again subclassified, and among those, one of the biggest group is the migraine. Then the commonest group is the tension type headache. Then there is a third group. Previously, the cluster headache was grouped separately, but now the cluster headache along with other headaches which actually having some autonomic symptoms in the face and head, and they are grouped together into one disease, that is the trigeminal autonomic cephalalgias. And definitely cluster headache is one of the most common type of trigeminal autonomic cephalalgia. And then we have the other primary headache disorder. For example, there could be a primary cough headache, primary exercise headache, primary headache associated with the sexual activity, primary thunderclasp headache. I am coming later. Then cold stimulus headache, external pressure headache, primary stabbing headache, nemular headache, hypnic headache, new daily persistent headache. Remember, this is one entity, that is the primary thunderclasp headache, where it is like a thunderclasp. That means it is a sudden onset headache. And remember, this is one of the common feature of the subarachnoid hemorrhage. So primarily, when seeing the patient, you should not diagnose a primary thunderclasp headache unless proved otherwise. Remember, because then you will be missing one red flag. Then what is nemular headache? Yes. What is nemular headache? It is a small area of headache in the head. It is a coin-like area and that causes pain. Now coming to the secondary headache classification, headache attributed to the trauma, injury of the head or neck that can cause headache. For example, a history, acceleration deceleration injury, that is the whiplash injury in the neck that can cause pain. Okay, headache attributed to the cranial or cervical vascular disorder, then headache attributed to the non-vascular intracranial disorder, headache attributed to a substance use or its withdrawal, headache attributed to the infection, headaches attributed to the disorder of homeostasis, headache or facial pain attributed to the disorder of the cranium, neck, eyes, ears, nose, sinuses, teeth, mouth, and other facial and cranial structures, and then headache attributed to the psychiatric disorder. So it all falls into the secondary headache group. Okay. Then third group is having the other neuropathies and facial pain, that includes the neuralgias like the trigeminal neuralgia, occipital neuralgia, glossopharyngeal neuralgia, facial neuralgia, optic neuritis, and central neuropathic pain. So that can cause pain as well. And remember, certain disorders like central neuropathic pain is quite common following a stroke. So you have to be careful while diagnosing. Okay. So ultimately you have to find out in which group your headache falls. And then we have the other headache disorders. For example, headache that not elsewhere classified and unspecified headache. They are the other headache disorders. Now coming to the primary headache disorders. Remember, among the primary headache disorders, it is the most common. First of all, in between the primary and secondary, primary headache is much more commoner than the secondary headache. And among primary headache, the most common type of headache is the tension type of headache. But most of the tension type of headache are usually self-limiting, or the patient usually takes a over a medication because the headache is mild to moderate, it's not severe, and it's a band-like feeling around the head. So in clinic, the patients come mostly are because of the commonest is the migraine. But in society, the most common type of headache is the tension type of headache, which is around 69%. Migraine is around 16%. Then idiopathic headache, stabbing headache like 2%, exertional 1%, cluster headache 0.1%. So it is further uncommon. Among the secondary headache disorders, the most common is the systemic infection, around 63%, followed by the head injury, which is 4%. Vascular disorder contributing to headache is around 1%. Subarachnoid hemorrhage is less than 1%. Brain tumor is 0.1%. Okay, so these are the main thing. The most Among the all types of headache, the most common type headache is the tension type headache among the general population, followed by migraine. Migraine is the most common type of headache that brings the patient to a clinic, and systemic induced infection induced headache is the most common secondary headache disorder. Okay, so we understood this part. Now coming to the red flags. So what are red flags? Red flags are the conditions where you have to manage immediately and it's an emergency. So what are the red flags? First of all, sudden onset headache, always a red flag. And it is also said if there is an worsening pattern of headache, that means change in nature, character or intensity of the headache should also be considered as a red flag. That means when there is a new headache over a chronic headache, that should also be considered a red flag. Headache in aged more than 50 years without anything, it could be a red flag. Then worsening pattern of headache, change in frequency and character, headache with systemic illness like fever, neck stiffness and rash, that could be a type of red flag. Then focal neuropathic signs or symptoms other than the typical visual or sensory aura, which is a part of the primary headache disorder migraine, classic migraine. If other neurologic signs occurs, they are always a red flag. Headache with papilledema, which could be possibly because of the intracranial tension increase. Then headache triggered by the cough, exertion, sexual activity, they are also should be a red flag. Then headache during pregnancy or postpartum, new headache in patients with the cancer or HIV, mainly the immunocompromised patients, that is also a red flag. Then headache associated with the metabolic disorders, acute hypertension and toxic ingestion, they are all red flags in headache. And sometimes there is a term that is called the yellow flags that comes a little below the level of the headache, that means red flags, but that is also a point of caution. That is the headache causing waking up in the patient, new onset side locked headache, that is one-sided headache, and postural headache. So these are also considered important but not as the red flags, but it is called the yellow flag. Okay, so in those cases further evaluation such as MRI brain is necessary. Now coming to the history. Remember, history is the main thing. That means in headache, the history is the one thing that you actually evaluate the patient, and with the history most of the primary headaches are diagnosed. Remember, it is not the costly tests, but it is the history and neurologic examination. Sometimes they will give you the maximum clue. So you should be knowing this art of history taking in headache. So what are the points in the history taking? First of all, ask for the chief complaints, history of present illness, treatment history, family history, occupational history, personal history, psychological assessment. In the history, few important points are, that is the age of onset. Remember, there are certain headaches that is common in older age, certain headaches that are common in younger age. Then duration, how long it is continuing, location of the headache, pain intensity, then character of the headache, frequency of the attacks, aggravating or relieving factors, progression of headache, specific history, aura symptoms, premonitory symptoms, impact on daily activity. So I'll be explaining each and every point here so that we can understand the history taking in headache in a better way. So let's start about the age of onset. Remember, most primary headache disorders usually begin in childhood or in early adult life. Okay, the most common age is between 20 and 30 years. And children or childhood migraine sometimes have a nausea, vomiting as a complaint rather than headache, and have high chances of developing migraine in their adulthood. Okay, because child might not exactly speak about the headache, but with the nausea, vomiting, we might have to think of that could be possibly a headache disorder of this child. New onset headache in older age should always be properly investigated. If there is a chances of the secondary headache due to vascular causes, there could be possible of the giant cell arteritis, there could be possible of the metastatic tumors or brain tumors, primary brain tumors, they are possible. So remember, aged patient you should always consider as a red flag. Now coming to the duration. Duration is also very important part in the history of an headache. For example, migraine usually a possible, it can be a very brief 4 hours, usually in young patient that happens, childhood migraine, but usually it resolves after taking adequate rest and drugs, and usual duration is around 72 hours. Okay, and childhood migraine can be a very short, but I have already told, but the usual migraine history is that the patient have the headache, then usually it resolves after taking medicine or on the next day, okay, and can last up to 72 hours, one attack. Then comes to the cluster headache. It lasts for seconds to minutes. Sometimes it is also called a alarm clock type of headache. That means coming in the same frequency on the day. For example, 7 o'clock in every evening. Or it could be possible that it is coming in every 12 hours or every 8 hours like that. Okay. And it usually lasts from seconds to minutes. So it could be a trigeminal autonomic cephalalgia. Then tension type of headache, it could last for 30 minutes to up to 7 days, and one of the very important characteristic that there is a band-like sensation. Then cervicogenic headache, which could last from few hours to several days, it is possible. Now coming to the pain intensity, usually migraine headache usually moderate to severe. Tension type of headache usually mild, but sometimes it could be moderate. Cluster headache is usually very severe, mostly unbearable, and patient may be banging the head against the bed or wall, generally agitated and walk to and fro. So severe headache is there. Basically, it's moderate to severe. Cervicogenic headache, it is usually moderate to severe, but sometimes could be mild as well. Subarachnoid hemorrhage, I have already told about this. It's a thunderclasp type of headache, so there will be sudden increase in the headache. Now coming to the location. Again, depending on the location, we could differentiate an headache. Usually, if there is a cervicogenic headache, usually comes from the back and then it goes up and up to the frontalis, it could go. Okay. For example, tension type of headache, I have already told it's a band-like headache. Migraine is predominantly a unilateral headache, and in cluster headache, usually there is a retroorbital pain along with the autonomic features of the same side. So these are usual for the cluster headache. Now coming to the location, so most commonly migraine is most commonly unilateral, but can present with the bilateral, alternate unilateral headache, or start with the unilateral and then progress to a bilateral or global headache. Whereas the cluster headache is predominantly unilateral and affect the orbit and adjacent areas, this type of headache do not change their sides. Tension type of headache, there is a band-like pressure. Cervicogenic headache, pain begins in the neck and refer to the frontal, temporal or orbital region of the ipsilateral side. Okay. Now character of headache, migraine headache, usually patient says it's a throbbing headache, that could be because of the vascular etiology. Tension type headache, already I have 10, it is a dull ache, band-like aching or pressure type. Cluster headache is a drilling pain or lanceolating pain, or sometimes it can be expressed by the patient as the boring pain. Okay. Then cervicogenic headache, attacks of the deep, non-throbbing and non-pulsatory type of pain. And sometimes in cervicogenic pain, the headache increases or decreases along with the movement of the neck. That also gives a clue. Trigeminal neuralgia, it causes a facial pain and very severe pain, usually associated with the brushing or talking, or sometimes in severe conditions even blow of air in the face and the affected area could initiate the pain. So that could be a pain of the trigeminal neuralgia. Coming to the frequency, the cluster headache, usually the cluster headache having a frequency of 0.5 to 8 per day. That means once in 2 days to up to 8 per day in a particular time of the day, like clusters. Okay, migraine, there could be possible up to 1 to 4 attacks per month. But remember, according to the frequency, migraine is also classified according to the episodic migraine and the chronic migraine. In chronic migraine, it lasts more than 15 days in a month. Okay, and tension type of headache, it could be often daily or it could be continuous. Remember, changes in the frequency of the headache may be due to transformation of one type of headache into daily or near daily headache. Okay, now coming to the aggravating factors. Migraine, there are some migraine triggers that we all know, like menstruation, ovulation, stress, hormonal supplements, empty stomach, some food sensitivity, environmental factors that such as fumes, glare, flickering lights, perfume or the chemical smell, exercise, red wine, and even late night can initiate the attack of migraine. And these are known as the triggers for the migraine. Then we have the cluster headache. It could be aggravated by the alcohol or sometimes the vasoactive substances like vasodilators of the nitroglycerin. Tension type of headache can be associated with the or increased with the stress. Cervicogenic headache, I have already described that it can increase with the neck movement or sustained occurred head positioning. And headache of the intracranial hypertension may change with the posture. Elevated intracranial pressure exacerbated by the coughing or the Valsalva maneuver, so that can increase the headache. Okay, so remember, headache is exacerbated in the changes in the sleep habits. Hence, all patients are advised to take proper sleep, especially the migraine patients. You have to avoid late nights. Okay, so these are all about the aggravating factors. Now coming to the relieving factors, migraine, that is the sitting quietly in a dark room. Basically, for the aggravating relieving factors, you don't have to know much. Just ask the patient what relieves your pain. And in migraine, the patient will say, I prefer staying in a cold, calm room. That time my headache is a little less. Okay. And after taking a Saridon or a paracetamol tablet, I usually get a sleep, and in the morning my headache is usually clear. In tension type of headache, there could be the rest and meditation that can actually reduce this thing. Cluster headache, we all know the oxygen inhalation via face mask for about 15 minutes can relieve the cluster headache. Okay, so these are the relieving factors for the headache. Now, progression of the headache. Remember, primary headache may progress to a chronic or recurrent or long-standing daily headache. Now, migraine and tension type of headache may evolve into a chronic migraine or chronic tension type of headache respectively when attack frequencies last more than 15 days a month for a successive 3 months, and which generally follows the same pattern for the headache at the same time of the day, months or years, and with a pain-free remaining part of the year. That could be possible, and that is more common with the migraine and tension type of headache, but it could be possibly happen with the cluster headache as well. Now, frequency of the headaches, secondary headaches occur in close retention of the etiology, and that reduce within the 3 months of the treatment, because secondary headache has happened because of the some associated disorder. When the disorder is treated, for example, a patient is having a systemic infection, the patient has been given antibiotic, and once the antibiotic has been given and it successfully treated the infection, then it could be within 3 months of the reduction of the primary pathology, it will also reduce. Now coming to the specific history. So in migraine, we all know 2 points we have to ask. One is the nausea, vomiting, and photophobia, phonophobia. Okay. So either any of the two should be present. Okay. And it is usually aggravated by causing avoidance of the routine basically patient wants avoidance of the routine physical activity, because actually that can increase the migraine. Now coming to the cluster headache, it is the ipsilateral autonomic symptoms like the nasal congestion, lacrimation, redness of the eyes, unilateral edema, flushing, sweating, fullness in ears, miosis, ptosis, that could be possible. So all the autonomic symptoms might be there in cluster headache, as well as the other groups of the trigeminal autonomic cephalalgias. In tension type of headache, there could be possibly a Pericranial muscle tenderness, especially in the temporal, frontal, and sometimes in trapezius, they could be present. Cervicogenic headache, there could be possibly reduced range of movement of the neck. Then there could be a non-radicular shoulder pain or arm pain. Sometimes there could be nausea, vomiting, photophobia, phonophobia, and dizziness, blurred vision, difficulty in swelling that might happen in cervicogenic headache as well. In trigeminal neuralgia, we all know eating, talking, washing the face, and even in, I have told you that in severe cases, the blow of air that could be painful. Patient usually asked to switch off the fan. That sometimes happen because these things trigger the attack for the patient. Now coming to the aura symptoms, that is also a very specific feature which is common in case of classic migraine. So basically aura symptoms starts usually after the premonitory symptoms, and they start gradually over a time of 5 minutes to less than 1 hour, which is followed by headache. Okay, so those symptoms will be coming before the headache. Okay, and they usually start to 5 minutes to 1 hour before the headache. And common aura symptoms are the visual aura symptoms, whereas there could be possibly the speech disturbance, motor loss, though they are very rare, that might happen. Okay, visual aura are positive and negative symptoms having the both. So this is one of the patient I am showing you the video. Let me share. Those who do not know Hindi, that could be a bit difficult for them to understand, but I will translate it later. So I am sharing the computer sound and I am just switching on the video so that you can actually know the history of the patient.
कितना तारीख था उस दिन बैंक जिस दिन हम गए थे? अच्छा, हम सैटरडे को बैंक गए थे। तो बैंक से आते वक्त ना मुझे लगा कि एक गुच्छा लाइट, लाल पीला हरा गुच्छा गुच्छा लाइट, हम सीधे ताक रहे हैं और वो लाइट फ्लैश बैक करते करते वो चला जा रहा है एक साइड में। मेरा भी नज़र उधर ही चला जा रहा है। फिर मैं सोच रही हूँ मैं क्या हो रहा है मेरे साथ में, फिर वैसे ही सीधे ताक रही हूँ, फिर एक गुच्छा लाइट ऐसे करते करते चला जा रहा है। और फिर जो सामने में कोई भी दिख रहा है उसका आधा फेस, मतलब एक नोज, हाफ नोज से लेके आई तक दिख रहा है। एक साइड में पूरा धुंधला ब्लैंक, कुछ पता नहीं हमको। कोई पिक्चर में देख रही हूँ तो उसका एक पार्ट दिख रहा है, ऐसे दो जन उस पिक्चर में है तो एक जन दिख रहा है, एक जन बिल्कुल नहीं दिख रहा है। ऐसा होते होते मैं चुपचाप घर आई, थोड़ा पानी वानी पी, रिलैक्स की। मुझे लगा ऐसे अटैक कुछ हो गया। उसके थोड़ी देर बाद रिलैक्स मिल गया, मुझे कोई प्रॉब्लम नहीं हुआ। बस हल्का फुल्का ढिकार उठने लगा, ऊपर की तरफ से ढिकार आ रहा था। उसके बाद फिर दूसरे दिन क्या हुआ, 12:30 बजे के बाद खाना खा ली, 4:30-5 बजे करीब इस पर चाय पी। फिर मैं दोबारा थोड़ा सा चाय पी। चाय पीने के साथ साथ मेरे हस्बैंड मेरे सामने बैठे हैं और उनका आधा फेस हमको दिख रहा है और एक गुच्छा लाइट, लाल पीला ऐसा लाइट गुच्छा गुच्छा जल रहा है, बुझ रहा है, जल रहा है, बुझ रहा है और फिर वही साइड बाई साइड चले जा रहा है। टीवी में कुछ हो रहा है, मुझे कुछ दिख रहा है। पिक्चर भी कोई भी दो इंसान है, मेरे सास ससुर का पिक्चर, मेरे ससुर जी दिख रहे हैं, सास जी नहीं दिख रही हैं। और सिर्फ एक आई के ऊपर आईब्रो से लेके फॉरहेड तक पेन स्टार्ट हो गया। धीरे धीरे पेन स्टार्ट हो गया। मुझे लग रहा है मुझे कुछ दिख नहीं रहा है, देखने का इच्छा नहीं कर रहा है, ताकने का इच्छा नहीं कर रहा है। उसका धीरे धीरे मुझे वोमिटिंग सेंस लगने लगा कि अब मुझे वोमिटिंग होगा। उसके बाद पेट में कैसा कैसा होने लगा और सिर्फ पानी वोमिटिंग हुआ। एक बार हुआ, दो बार हुआ, ऐसे करके 4-5 बार हुआ और मैं एकदम लस्त पड़ गई। मुझे कुछ अच्छा नहीं लग रहा था। फिर थोड़ा देर बाद मुझे सब कुछ सामान्य दिखने लगा कि हाँ, दो पिक्चर में जो दो जन है वो दो जन है। फिर हस्बैंड का भी फेस पूरा दिखने लगा। पर उस दिन से 2-3 दिन तक टीवी देखने का मन नहीं करता था, क्योंकि देखती थी ना तो आँख पर लगता था प्रेशर पड़ रहा है, या फिर किसी से बात करने का मन नहीं करता था। जिस साइड में आई में, एक साइड में जो आईब्रो पेन फट रहा था दर्द से, उस साइड से तो हरगिज़ किसी से बात करने का मन नहीं कर रहा था। और बहुत ज़्यादा वोमिटिंग होने के चलते शरीर में ना अफर्ट नहीं हो रहा है कि मैं खड़ी हो पाऊँ या बैठ पाऊँ। सिर्फ सो रही हूँ, जब बिछौने पे जा रही हूँ तो नींद आ जा रही है। और ये पेन मेरा लगातार 2-3 दिन तक रहा। आज मेरे को थोड़ा रिलीफ है, पर बॉडी मेरा सपोर्ट नहीं कर रहा है मैं खड़ी हूँ या मैं चल पाऊँ।
So basically, the patient is describing that suddenly she is seeing some red and yellow lights, and then there is a scintillation scrotoma. So basically, he is able to see the visual field is lost and there is some scrotomas there, and he actually can actually see partially. After that, there is pain, and followed by there is vomiting as well as the patient described about the post-drawn phase also. So that was about the headache. So basically the patient's description is such vivid that it clearly says that it is a classic migraine. But remember, not in all cases it will be the same. So what are the aura symptoms? Common aura symptoms are, like the patient was saying, the flashing light, zigzag lines moving across the visual fields. Then scintillation, sclerotomas, bright gleam of light around an area of the visual loss. Then visual resizing or reshaping of the object. Then negative visual symptoms include the visual field defect, blurring or sclerotomas, numbness or tingling of the face, arm, hand, or one side of the body. Then there could be muscular weakness or mild paralysis of one side of the body. That's basically hemiplegic migraine. And then there could be difficulty in speaking, or loss of speech could be possible. So these are the usual aura symptoms, but remember, visual auras are the most common, others are comparatively rare. Now, after the aura symptoms, we have the premonitory symptoms. So that means they actually starts with this premonitory symptoms. So the patient of migraine can predict the arrival of the headache because of this premonitory symptoms. So how to elicit these symptoms? Just ask the patient that whether before your headache is arriving, do you understand that your headache is going to come? So usually the patient is able, because they are having successive headaches, and they could able to describe these symptoms. There could be possible hypoactivity, depression, craving for a particular food, then repetitive yearning, fatigue, low concentration, altered sleep pattern. Remember, the aura symptoms might be varied patient to patient, but usually it is consistent in one patient, so that the patient usually is able to say that these are my aura symptoms. They don't say aura symptoms, but by these symptoms I am able to understand that my headache is going to come. Next is the impact on daily activity. Remember, headache is one of the, I should say, worst disorder which impacts the activity of human being. Okay, it is important to know the impact on headache on the daily routine activities for the proper management of the headache and reducing the morbidity of the patients. The impact on this headache is the patient's life can be measured using a headache impact test. They are actually questionnaire based tests. Then migraine disability assessment questionnaire, and they are available online. So if you search with this, then we'll be able to see those. Okay. Now past history of migraine or past history of headache, that is also very important, because detailed past history, change in character, pattern, severity of the new headache that could be elicited. You have to go for the past investigations and past treatment history. That helps us to understand whether it could be a possible. So patient of migraine sometimes can have the history previously. So with that, it will help us to know about the type of disease as well as the type of the headache, whether it is episodic or whether it is chronic, so that we will be able to understand. Now coming to the medication history, sometimes there are certain medications that can increase the headache, especially for the migraine, like oral concentrate contraceptives, hormone replacement therapy, nitrate. So basically, they can actually increase the type of headache. Okay. Patients with a chronic primary headache like a tension type headache and migraine may develop a rebound headache due to the or a headache due to the medication overuse. Okay, that is also possible. Now coming with the comorbidities that we have to ask for the patient. For example, the patient with asthma, we should avoid the beta blockers for the migraine. Then hypertensive patients with headache, beta blocker prophylaxis for the migraine that can be given. Headache with the depression and insomnia, we can go for the treatments like amitriptyline. In in the patient having the history of other carcinomas, we can think of metastatic lesion, and we have to take the history of the dental, nose, sinus, and ear abnormalities, and history of head trauma. We have to suspect the post-traumatic headache or subdural hemorrhage or the extracranial arterial dissection that we actually able to understand. So these we have to ask to the patient. In the family history, there could be possible the hemiplegic migraine is having documented genetic influence, but it is of a rare type, and secondary headache like a cerebral aneurysm, it could be possible that it could be a family history present, like brain tumors as well might run in the families. Now coming to the physical examination, remember there is always a paucity of the examination findings because the majority of the headache is having the normal examination findings. But if subnormality abnormalities are detected, then other investigation and imaging should be immediately done because these are usually not primary headache. Okay. So in general examination, we have to check the body habitus, fever, neural rigidity. So if there is a obese patient, there could be possibly migraine or idiopathic intracranial hypertension, patient with having the neck rigidity, redness in the temporal region, there could be possible meningitis, encephalitis, giant cell arteritis. Okay, and in those cases, we have to go for the blood count evaluation. Differential blood count, ESR, CSF routine microscopy should be done on those cases. Patient with hypertension, there is possible hypertensive encephalopathy, which could be possible cause of the headache. Now coming to the skin changes, though usually it is not easy to find out this. This requires a lot of clinical practice to find out those. For example, a herpes zoster scar could be possible a PHN is there. Then a malignant melanomenclation could be a metastatic disease in the brain. There could be redness, edema along with the superficial temporal artery. There could be possible giant cell arteritis. Capsular spots might be present along with the patient with the neurofibroma and neurofibromatosis, and there could be intracranial meningiomas or schwannomas that can be causing the headache. But remember, these are actually rare things. In routine practice, you will not be getting those things. In the systemic examination, we have to check for the higher function like memory, concentration, orientation, speech. Then we have to inspect, palpate, check the range of movement of the neck that we have already described with the cervical pain, and we have to go for the cranial nerve evaluation. And for the neck, we have some special tests, and this time we are already learned about those tests. And exam is generally normal in primary headaches, and these disturbances could be there in secondary headache only. In the inspection, we have to check in the neck for the local inflammation, neck rigidity, face check for the symmetry of the both sides, inspect eye, nose, ear, teeth to rule out local infection which may be cause of the headache. In the scalp, you have to check for the swelling, redness over the scalp to rule out the local pathology as a cause of the headache. In the palpation, we can check the tenderness over the scalp. That could be possibly a common feature in the tension type of headache. Tenderness over the sinuses could be possible in a case of acute sinusitis. Tenderness over the superficial temporal artery, that could be possible because of the giant cell arteritis. Then temporomandibular joint tenderness, there could be possible TMJ arthropathy, tenderness over the neck and the paramedian region, that could be because of the cervical facet pain or could be because of the myofascial pain. Passive stretching of the paraspinal muscles will increase the tenderness and difficulties in myofascial pain syndrome and facet joint arthropathy. Basically, in cervicogenic headache, there could be possible that the neck movements may be increasing or decreasing. Similarly, the pressure over the cervical spine could be painful in those cases. Range of motion, it could be affected in the cervicogenic headache, and check for the flexion, extension, lateral bending and rotation. Lateral flexion is the earliest of the most important movement in degenerative disorders. Basically, in lateral flexion, what happens? The facet gets overstretched of a specific side. Now we have to check for the cranial nerve evaluation that we have learned in our UG days, that you have to complete it to find out. Special tests, we have already learned about those tests like the Sparlang test, Jackson compression test, and that could be possible cause because of the radiculopathy. Now coming to the investigations, remember in investigation actually what we get is very limited in primary headache. So plain X-ray, that could be cause and show a skull fracture or a trauma to the cervical spine, and it can rule out the major pathologies of the cervical spine, and it is routinely done because of the its cheap nature, but the amount of information that we get is very limited. CT scan, it is good for the bone again. It could be possible to check for the fracture, paranasal collections, and the intracranial lesions. But remember, the best here is the MRI for the soft tissue than the posterior fossa, because in the CT scan, the posterior fossa is not properly evaluated. So MRI gives better idea about the soft tissues like tumors, okay, including the posterior fossa, metastatic lesion, brain abscess, meningitis, tubercular infection, and various malignancies like Arnold Chiari malformation, ventricular obstruction leading to the raised CSF pressure and the headache. Hemangiography, venography can sometimes be done for the aneurysms, or sometimes there could be the anomalous arteries compressing on the specific nerve that we can evaluate without the hemangiography. Sometimes in trigeminal neuralgia, we ask for this to find out whether there is any apparent vessel or not. It also locates a vascular loop compressing over the trigeminal nerve, which can be the cause of the trigeminal neuralgia. MR venography is done in case of the cerebral venous thrombosis. Now coming to the diagnostic criteria. Remember, these diagnostic criteria are huge to remember. In every case, you won't be able to remember all the criteria, but the common cases like migraine, like tension type of headache, or like cluster headache, these criteria usually with time you will be able to remember, but it is not an issue. If you are getting the patient of same kind, you can check in the internet. They are all available in the International Headache Society's website, and after that you start practicing, and once you start seeing the patients, then automatically you will be able to remember that, because these are very self-explanatory. Remember, in migraine without aura, that means common migraine, there should be a 5 attacks which fulfill the criteria B to D. Okay, so what are those? First of all, B is the headache attacks last for 4 to 72 hours, and which is if untreated or unsuccessfully treated, then it will last for the 4 to 72 hours. Sometimes the patient might take a painkiller and that could resolve it early, but if kept untreated, it will be lasting for that long. Next, headache should have any two of the following characters, like unilateral rotation, then pulsating quality, moderate to severe pain intensity, aggravation by causing avoidance of the routine physical activity, example walking, climbing stairs. So that can actually increase this pain. So that any two of them should be present. Then any one of the following features in the D, one is the nausea and or vomiting, and photophobia and phonophobia. Sometimes any one of them will be present. So any one of the two should be present. Okay. So then E states that it should not be better accounted with other ICHD3 diagnosis. As I initially told, in ICHD3, always you should remember the best match you have to find out. So this is the very common condition, that is the migraine without aura. Next comes migraine with aura. The patient should have at least 2 attacks fulfilling criteria B and C. So what is B and C? In the B, there should be one of the following fully reversible aura symptoms. Remember, aura symptoms, whatever bad it might be, it should be fully reversible. It could be possible a visual aura, a sensory aura, speech or language difficulty, a motor aura, a brainstem aura, and retinal aura. So that could be possible, among which it should have one or more reversible characteristic. Okay, and at least 3 of the following 6 characters, at least one aura symptom spreads gradually over more than 5 minutes. 2 or more aura symptoms occur in succession. Each individual aura symptoms last for 5 to 60 minutes. At least one symptom should be unilateral. At least one aura symptom should be positive. And if the aura is accompanied, it should be followed within 60 minutes by headache. It should be there. So at least 3 of the following symptoms should be there, and in the D, it should not be better explained by any of the ICHD3 diagnosis. And remember, in all cases, it should not be explained by other diagnosis. That is very, very important. And TIA should be excluded here in case of migraine with aura. Next, come with the tension type headache. Again, episode in A, it is the episodes occurring in the frequencies below. Number 1, infrequent episodic TTH, at least 10 episodes of the tension type of headache occurring less than 1 day per month, to average less than 12 days per year, and fulfilling criteria B2D. B2D is the main thing, and it is divided into infrequent episodic, frequent episodic, and chronic episodic. The criteria for the infrequent episodic is the at least 10 episode of the headache, less than 1 day per month, or average 12 days per year. Okay, less than 12 days per year. Whereas the frequent TTH, at least 10 episodes occurring in 1 to 14 days per month. Average, on average, it is more than 3 months it is happening. And in the chronic headache, it should be lasting for more than 15 days per month for more than 3 months. Okay, and headache should be lasting for 30 minutes to 7 days. Headache has at least of the two of the following characteristic, that is the bilateral location, pressing or tightening quality, then mild to moderate intensity, not aggravated by the routine physical activities such as walking or the climbing upstairs. And both of the following, both should not be there. Basically here there should be no nausea, vomiting, and no photophobia or phonophobia. So basically these two are a characteristic, any one of them should be present in the migraine, but it should not be there in case of tension type of headache. And in the E, it should not be better accounted by any other ICHD3 diagnosis. Similarly, clustered headache is having these characters, at least 5 attacks fulfilling criteria B2D, severe or very severe unilateral, orbital, supraorbital, or the temporal pain lasting for 15 to 180 minutes when untreated. Number C, either of or both of the following among the 1 and 2. Headache is accompanied by the at least one of the following features, like these are basically, I have already discussed, these are basically features of the autonomic sensor, somatic features. Okay, so on unilateral autonomic facial features, any one of them should be present, and a sense of restlessness or agitation should be present. Then attacks have a frequency for one every day, that is 0.5 to 8 should be the frequency of the attack. It is not accounted better by the any other ICH3 diagnosis. So these are the major classifications. And next come to the cervicogenic headache. So any headache fulfilling criteria C, B, clinical laboratory or the imaging evidence of the disorder of the lesion within the cervical sign or the soft tissues in the neck known to be generally accepted as a valid cause of the headache, and evidence of the causation demonstrated by the at least two of the following. So headache was developed in the temporal relation with the onset of the cervical disorder, has significantly improved or resolved in parallel with the improvement or resolution of the pathology. Cervical range of motion is reduced and the headache is made significantly worse by the provocative maneuvers. Headache is abolished following the diagnostic blockage of the cervical structure that nerves supply the diagnosis. So basically what it says, if there is a facetogenic pain, we will be blocking the nerves of the facet joint and it should give a relief. And last point is definitely the same, that is it is not better accounted by the any other ICHD3 classification. Next come to the secondary headache. So again, it is, I'll share all these criteria to you because I am reading the slide. It is very difficult to remember. Neither I am remembering and I am not expecting you to the remember, but you should keep it along with you during the practice to find out. But first you have to find out which type of headache it is. Okay. Now coming to the neuralgias. Okay. In the neuralgia, the most common neuralgia is the facial neuralgia that commonly we treat is the trigeminal neuralgia. So in trigeminal neuralgia, the patient usually having a shooting shock-like or electric shock-like stabbing pain in one side of the face, and it is always moderate to very severe, and the pain attack lasts for a very short duration, but usually seconds to minutes. But there could be successive attacks, okay, and that can cause a lasting pain, okay, and then it could be periodically increasing or decreasing. There could be possible, but some duration the attacks are comparatively less, and it is mostly unilateral, and it is in the location of the trigeminal nerve. We all know trigeminal having three divisions. This is the ophthalmic, this is the maxillary, this is the mandibular. So it should be any one or two divisions of the trigeminal nerve. In our further classes, we will be learning about the trigeminal neuralgia in lot, and this is a condition that is mostly exclusively treated by the pain physicians. So you have to know about all about the trigeminal neuralgia. Next, there could be a triggering factor like light touch, patient eating or patient speaking or patient washing the face that could be increasing the pain. And alleviating factor is definitely the sleep or sometimes the anti-epileptics. We all know the drug of choice for the trigeminal neuralgia is the carbamazepine, and the second choice is the oxcarbazepine that should relieve the pain. And accompanying fracture, there could be some trigger zones, some poor quality of life should be there, and sometimes the patient is not able to eat, so ultimately that can cause a weight loss for the patient as well. Now coming to the diagnostic blocks. So there are some diagnostic blocks that helps to find out the cause of the headache. For example, in case of occipital neuralgia, it could be a greater occipital, lesser occipital or third occipital neuralgia. Blocking the specific nerve can relieve the pain. Trigeminal ganglion block, especially the local anesthetic block, helps to diagnose the trigeminal neuralgia. Sinopalatine ganglion block helps to reduce the cluster headache. There are two types of block here also. One is to the lateral side, one the intranasal route that we will again be discussing with the sphenopalatine ganglion block that could relieve the cluster headache. Then C2 C3 medial branch block, that is basically a cervicogenic pain that can be blocked with the C2. If the origin is the C2 C3, basically here the third occipital nerve which is going just over the C2 C3 facet joint is getting irritated, and when you block this it will actually relieve the pain. Cervical epidural is helpful in case of the disc disruption or cervical radiculopathy. Trigger point injection are useful for the myofascial pain syndrome. So we'll be learning all and every procedure here. We have already learned few procedures like a facetal pain, how to manage, and we have also learned about the epidural and the radiculopathy. Next things regarding the trigeminal neuralgia and occipital neuralgia we will be learning with time. Okay, so that was all about the evolution of the headache and facial pain. Remember, it's a complex topic, but with practice and reading, you have to do both. It will be easy. It is not difficult, but most important is your eye to find out, take the history out, and then match with the disorder. Sometimes I say like that there is an ocean of symptoms and there are some islands, our known islands. One island is migraine, island is the tension type headache, one island is the cluster headache. So we have to pull the patient to our specific island for the treatment. It is like that only. So any questions? It's a complex topic. There could be many questions, but if you have anything, you can just ask. Okay. So
Yes,
today
sir.
evening I forgot to show you the result, last test result. So I'll be sharing the last test result in the chat soon. Okay. When the Chinmada is actually teaching you the glossopharyngeal neuralgia. So Chinmada, can you start?
Yes, yes. So today's topic is actually most of the theoretical topic, but these are very important because when you run a pain clinic, you cannot choose patients in that way. Let's say I will see a case of, say, trigeminal neuralgia, but not other neuralgias, or I will see a case of cluster headache, but not other headache. So you cannot choose like that. Patient of headache will come, and you have to be able to distinguish or classify that what you are treating. So in these, whether it is a neuralgia or it is a headache, the most important thing is to understand what is primary and what is secondary. In primary, we treat only the symptoms. In secondary, it is not the symptom. We have to understand that why this symptom is happening. So when secondary cause is there, we most of the time we will send the patient to the respective consultant to treat the main cause. And of course, if needed, the palliative part, symptomatic part treatment also will continue. Okay. So now Devjyoti, are you sharing that result?
Hello?
Are you sharing the result or I should share?
Just 1 second. Have you got it?
No, no, I did not search.
Okay. I'm sharing just within 2 minutes. Okay. I will
Okay.
stop you for a very brief time and I will share the result. Okay, you can start now.
Okay. So, mm, okay. So I will talk about the glossopharyngeal neuralgia. As I was saying that first we need to know that primary or secondary, and then when we are seeing say headache part already is has been told. Now I'm talking about the neuralgia. So basically, all the neuralgias are somehow it is similar. These are not much different. How? Few things like the presentation. So presentation, neuralgia presentation is always it is similar, be it any neuralgia. So pain will come and go. Pain will be very short-lived. Okay, and so neuralgic pain and pain is severe. Most of the time, it is very severe pain. So these are common things of neuralgia. And neuralgia means nerve is painful. Okay, pain in the nerve distribution. But there is another term that is called neuropathy when there is demyelination of the nerves, and that type of pain is also common whatever be the nerve. So that is constant pain, one background constant pain. So that is called neuropathy. Whenever we say trigeminal neuralgia or say glossopharyngeal neuralgia, we want to say that just pain comes and stays for 1 second or 2 second or few seconds, and then intermittently between the pain there is a complete pain free interval. But when we will say neuropathy, either it is trigeminal neuropathy or it is glossopharyngeal neuropathy, so there is a background pain. And then treatment also. So this is the presentation, and our treatment also sometimes it is similar. Most of the treatments which are applicable to trigeminal neuralgia, they are applicable to glossopharyngeal neuralgia also. So let us see.
Okay, so altogether, this is the list I have just posted. So a good number of candidates. Altogether, 9 candidates have scored 40 out of 40. Abhishek Kumar Gupta, Deepak Rana, Divya Chandrasekhar C, Mamta Demar, Nidhi Patel, NG Tiang Sun, Nairali Prajapati, Shankalp Mohan, and the Shashank Pandey. So congratulations to all of you. So everyone is now attempting the test very seriously, and they are getting 40 out of 40 type of marks. Congratulations to all.
Okay, at least everyone should attempt. Otherwise, I mean, there is no meaning. Okay, so let me continue. Overview of glossopharyngeal neuralgia is glossopharyngeal neuralgia is a rare neurological condition. So it is less than 1 in 1 lakh population. Okay, characterized by severe recurring pain in the back of the throat, tongue, tonsil, and ear. So you can see the distribution is different from trigeminal neuralgia. It is a differential diagnosis of trigeminal neuralgia, but and pain characteristics also same, but not at the same place, not in the trigeminal distribution. It is in the back of the throat, tongue, tonsil, and ear. So how it is triggered? Triggered by actions like swallowing, coughing. So these, I mean, many triggering action can be similar in both the cases. Episode lasts from second to minutes, caused by irritation of the glossopharyngeal nerve, can significantly impact quality of life. So this is a common description for any neuralgia. See, this is a ICSD classification. So I'm not going in detail of it. Just see. So few things are important. Recurring paroxysmal attacks of unilateral pain. So you understand both trigeminal or glossopharyngeal. These are paroxysmal attacks, okay, and recurring attacks and unilateral last from few seconds to 2 minutes. Severe intensity, electric shock like shooting, stabbing, and sharp in quality, and precipitated by swallowing, coughing, talking, or yawning. So, talking or even swallowing can precipitate actually both trigeminal also and glossopharyngeal also. And this is the most important line, not better accounted for another ICSD-3 diagnosis. So this type of diagnosis, which we always diagnose by clinical symptoms, there we must search for all other possibilities. At least the secondary causes must be searched. So this is a ICSD-3 classification. Now, to understand all the different types of, so you see here it is written that pain, it is where it is going, okay, base of the tongue, tonsillar fossa, and beneath the angle of the jaw. So distribution, if you want to understand, then you have to understand the anatomy of the ninth cranial nerve, that is the glossopharyngeal nerve. So firstly, it is a mixed nerve. It has motor and sensory both. Of course, parasympathetic autonomic functions are also there. Now, four nuclei from in medulla oblongata, from there it starts. Okay, and then it comes from the cranium to extracranial part through the jugular foramen. So these are jugular foramens. So here, if you understand, this is the anterior side and this is the foramen magnum, so posterior side, and these are all three foramens. Of course, we cannot see the trigeminal areas. So this is the foramen ovale. Then this side foramen rotundum, foramen spinosum, and these are the jugular foramens. So these are in the posterior cranial fossa. These are the jugular foramen. So from there, it is the glossopharyngeal nerve which passes from medulla. Okay. Now you see sensory branches. Tympanic nerve. It has one branch, that is tympanic nerve. So the this branch, this tympanic nerve, this part, so it ultimately supplies the middle ear or internal surface of the tympanic membrane or eustachian tube. So you can understand that in a glossopharyngeal neuralgia, pain can radiate to ear. Then comes carotid sinus nerve. Okay, so carotid sinus nerve, it supplies the carotid sinus and carotid body. So information of this one, your blood pressure and SpO2. So these things, oxygen concentration and all. So these are also received, or I mean, it has a supply to the carotid sinus. So here, these in glossopharyngeal neuralgia, there is when there is a pain, then patient can have bradycardia or say hypotension. So there is a chance then there is a vital instability also you can see during pain. Somebody is not muted. Okay, I am muting. Okay, so by seeing the all the nerves, these different sensory branches, you can understand that glossopharyngeal pain, glossopharyngeal neuralgia pain can go to which places and show all other different sensory symptoms. Now, terminal branches, pharyngeal branch, so mucosa of the oropharynx, it is supplying, and tonsillar branches, so palatine tonsil, and then lingual branch, so posterior 1/3 of the tongue with taste sensation also. Okay, so these will be affected in a case of glossopharyngeal neuralgia, and distribution also the same type of distribution. Spatial sensory, so spatial sensory means taste sensation. Okay, so posterior 1/3 of the tongue. So here, I mean, the taste sensation patient may be affected. Now comes motor function. So this stylopharyngeus muscle here, the of the pharynx, I mean, it is innervated by the glossopharyngeal nerve. So this stylopharyngeus muscle can get affected if if there is a nerve compression. Parasympathetic supply is to the parotid gland. Okay, so here you can see that in this picture, so these line diagrams by black ink. Okay, so these are muscles. Here it is the styloid process. Okay, so this is very important thing. So we understand that okay, this styloid process is very important for procedure purpose, from all procedure point of view. So here it is the anterior side and this side is posterior side. Okay, this mastoid we can understand, this is mastoid. This side, of course, the mandible is not there, has been removed. So this is the mandibular fossa, and this is the styloid process. From styloid process, what are the muscles and ligaments are attached? One is styloglossus, one is stylohyoid. So these are muscles, and one is pharyngeal muscle. So this one is also stylopharyngeal muscle. So there are three muscles and actually two ligaments. One ligament is here, you can see this is stylohyoid ligament. Of course, another ligament is stylomandibular ligament. So these two ligaments are there. So and three muscles are there. So these ligaments are important. Why these ligaments are important? These ligaments can get calcified. Okay, partly or even completely, these ligaments can get calcified. So you see the anatomy of this area. So here you can see there are some vessels. So these are external carotid artery, internal carotid artery. The deeper one is internal carotid artery, and upper this side it is the external carotid artery. And these nerves are not a single nerve. There are multiple nerves. You see facial nerve, spinal accessory nerve, and then there has to be the vagus nerve also that is there, and then glossopharyngeal nerve. So all the nerves are actually together, and then these are all just over the internal carotid artery, and above them this is the styloid process. So remember this anatomy from superficially, from one side if you see. So superficially it is styloid process, bone, and then it is the nerves. Of course, nerves are around the vessels, but vessel is a bit deeper. Vessel means internal carotid artery. Okay. So now you see that this styloid process here, of course, this is the picture of an elongated styloid. So this is the elongated styloid. So do you think it is the complete styloid? No, it is actually the some calcified portion of the ligament has also mixed with the styloid process. That's why it has become the elongated styloid. Here, as you can see, usually between 3 to 4 centimeter. Sometimes it becomes elongated. Now, this is a 3D reconstruction page. So you can see that this is big, long styloid. Okay, these are elongated, calcified styloid. Here you can see that this from here to hyoid bone. You can see this is the hyoid bone. So what is the name of the ligament here? Anyone can say?
Stylohyoid.
Yes, this is the stylohyoid ligament, completely calcified. Okay, so here, so this is also a 3D reconstruction. Here it is not completely calcified, but again, this stylohyoid is completely calcified. So this anatomy is important, this part. For diagnosing, as I told you, first you will diagnose by the symptoms that whether it is a neuralgia or not, which type of neuralgia. Then you will think about that whether it is primary or secondary due to some causes. Okay, then of course we will have to see, we have to understand the pathology. Then we have to understand the anatomy mainly. So you see this ball, this left-sided circle is glossopharyngeal neuralgia. Right-sided circle is Eagle syndrome. Glossopharyngeal neuralgia and Eagle syndrome are not same, but it is similar. How come? Glossopharyngeal neuralgia means just neuralgia of the glossopharyngeal nerve. Okay. Now, this part is common. How come? So, compression by vessels, cyst, or tumors, or even multiple sclerosis or other systemic causes, all these things causing trouble to the glossopharyngeal nerve is glossopharyngeal neuralgia. But compression by long stylohyoid and styloid mandibular, stylohyoid and stylomandibular, these two ligaments, as I told, and even long styloid also, if the bony part is also a bit long. So in these cases also, if only the glossopharyngeal nerve is affected, then we will say that this is it is a case of glossopharyngeal neuralgia. Causes are different, but the affected part is glossopharyngeal neuralgia. So here important is in glossopharyngeal neuralgia diagnosis that which nerve is affected. Okay, but in Eagle syndrome, which nerve is affected is not important. Important is what is causing the issue or problem. So in Eagle syndrome, it is mainly the long styloid or stylohyoid or stylomandibular calcified ligaments. Okay, so these are, if pressing only the glossopharyngeal neuralgia, then also we will say it is Eagle syndrome. Then it's okay that it is causing only the glossopharyngeal nerve, but it is a part of Eagle syndrome because stylohyoid stylomandibular ligament, that is the main compressing structure, and again it can not only compress in Eagle syndrome when these are calcified, it can not only compress the glossopharyngeal nerve, it can compress other nerves also: trigeminal, facial, glossopharyngeal, and vagus nerves. Facial is very much affected. Vagus is very much affected, can be. Okay, so these are also, as I showed you the picture, these are also very nearby together. And it can also compress the carotid artery even. Okay, so here you can understand in this circle, when we say Eagle syndrome, then we want that something of this part is there with the glossopharyngeal neuralgia. If or it is not a pure glossopharyngeal neuralgia, there is some amount of symptom which shows us that that is facial nerve is also involved, or even the carotid artery is also involved. It will be said as Eagle syndrome. Understood? Pain characteristics, so all neuralgia are same. Sudden sharp stabbing pain in the back of the throat, tongue, ear. So see, tongue, ear, or tonsil area. So this is the area, and triggered by swallowing, coughing, talking, yawning, and pain episodes last seconds to few minutes, up to 2 minutes actually. So these are all neuralgia characteristics. Here, so remember, if in Eagle syndrome, this is Eagle syndrome pain characteristic, not glossopharyngeal neuralgia. Glossopharyngeal neuralgia will be a subset in this case. So in Eagle syndrome, cranial part, if cranial nerve is impingement, then you can see that not only the glossopharyngeal area problem will occur, if there is some other, say facial paresthesia, dysphagia, swallowing problem, then foreign body sensation, globus hystericus, it is told, or pain on extending the tongue, sensation of hypersalivation, tinnitus, otalgia. So these symptoms are there. So you can think that other cranial nerves are also affected. Okay, and most of the time, if you palpate the styloid process, symptoms should increase. Okay, and if it is a carotid impingement, which is very rare, of course, then patient can have ischemic attack. Okay, so mechanical compression such as visual symptoms, syncope, fainting, or carotid dissection. So these things can occur. Yeah. Or carotidynia. So these things also can occur. So main thing is when you are suspecting that, or clinically you are thinking that, okay, this is a case of glossopharyngeal neuralgia, then always think about Eagle syndrome also. If you have seen a very thickened ligament, calcified ligament of this one, stylomandibular or stylohyoid ligament, then always go for an MRI or 3D reconstruction of CT, and you see that, mainly MRI, for if there is any other secondary cause also, or any other nerves are affected, or there is any other reason to say to understand that why other associated symptoms are there. Now, as I told you, neuralgia means pain comes and goes, and neuropathy means demyelination has occurred already. So continuous some pain is there. Primary, secondary, idiopathic, this classification is same as trigeminal neuralgia. Primary means when there is a vessel compressing the nerve. So it is primary. Vessel is, I mean, not much given importance in this way that it is primary. It is included in primary. Secondary, if other than vessel, any other compression is there. Idiopathic means there is no vessel also, nothing else also. So there is no reason found. So these three types of classification is there. Diagnosis, so clinical evaluation and history taking gives us a very, makes a gross diagnosis immediately. And then MRI, CT scan to identify structural causes and diagnostic nerve block. So this is also very important, diagnostic nerve block. Because I will say that glossopharyngeal neuralgia is very satisfying for treatment, because patient gets a very good relief. Even with the diagnostic nerve block, patient gets very good relief. Okay, so we have actually, though it is too much rare, but still in our practice, me or Dr. Datto, everyone has got many glossopharyngeal neuralgia cases. It's not that uncommon. So diagnostic nerve block is also for diagnosis. Then medical management, it is similar for all anticonvulsant like carbamazepine, gabapentin, pregabalin, so all those drugs. Antidepressant like amitriptyline, nortriptyline, duloxetine, so all these drugs for same for neuropathic treatment. Okay, if medical treatment fails, then what we can do, we can go for intervention. So one intervention, one option is local anesthetic plus steroid, though this option is not there for trigeminal neuralgia, it is for glossopharyngeal neuralgia. Second option is radio frequency. Radio frequency can be of different type. Pulse radio frequency modulation, immunomodulation, neuromodulation, not immuno. Neuromodulation means we are not destroying, we are just interrupting the pain pathway signals. We are interrupting, we are not destroying the fibers. And otherwise, option is thermal RF. Thermal RF means conventional RF or cooled RF also. Cooled RF is also thermal RF. Okay. So all these things can be done. But of course, I told you that this is a motor mixed nerve. Motor sensation is also there. So some side effects are expected, though every time it is not seen if I destroy the nerve then also. So this is earlier method described in some books, but of course nobody is going for, we are at least not going for intraoral injection. So this is palatine tonsil just below the pillar of the palatine tonsil. In this area you go for the injection, but then we are not doing this procedure. Here RFA of glossopharyngeal nerve, you can see radio frequency ablation. So this is a paper came in 2024. Here you can see if you do RFA in this paper, as I saw dysphagia, dysesthesia of their tongues, and developed a diminished gag reflex following treatment. So side effects are expected if you destroy the nerve. But of course, these were all managed within 1-2 weeks. So patient became all right. And we also did this type of procedure. So it was manageable. So this is RFA. In this paper, you can see there are so many papers. And ablation RFA, ablation was also done, pulsed radio frequency also done, and cooled radio frequency has also been done. So all people cooled radio frequency. So people have tried everything. Okay, and most of the things, most of the papers, they are giving a very high score of success. 100% pain relief, 100%, 100%. So many 100% pain relief. And as I told you, glossopharyngeal neuralgia treatment is very satisfactory, like trigeminal neuralgia only. RFA gives very good result. And most of the time, if you don't diagnose, if you don't do intervention, then patient do not have an option, because neurologist's treatment after few days only it fails, and surgery is not very easy option. And for ablation also, we should not think that much, because surgeons, neurosurgeons do neurectomy. So if neurectomy patient can tolerate, then ablation also it is very easy to tolerate, because in our ablation always nerves regenerate. So pulse radio frequency, glossopharyngeal neuralgia. So remember, so this is a lateral view, and this is AP view. AP view is not much important here. Uh, you can see, but this is a AP view and this is a lateral view. But let us see that where you should search for the, if you are doing the procedure under X-ray, then where should you search for the, this one, your glossopharyngeal nerve. So you can see, first see the right picture. So this is the angle of the mandible, and this is the your C1 vertebra. C1, you can see odontoid process, and this is the anterior part of the C1 vertebra. So between this C1 vertebra and this uh, this mandibular ramus. So this area, this is the styloid process. This arrow marked area, this is the styloid process. So here also, if you see, it is a bit difficult to understand, but when we will try to hit the styloid process, so we know, so this is the C1 and this is the ramus of the mandible. Between these area, we will always search for the styloid process. Okay, so let us see when the procedure. So here you can see, you may be very lucky in some patient, and you see that big calcified stylohyoid ligament. So this is from styloid process to hyoid. So here you can very easily see, very easily identify, but it is not the case in every case, every patient. So here also you can see, you will search in front of the C1, and then behind the angle of the mandible. Okay, so in this area we will search. So here, okay, so this is a ultrasound guided. This is a ultrasound, not this is a X-ray guided positioning. Now, just a minute. Okay, this is a X-ray guided positioning. So there is a small technique is there. Okay, so here, in X-ray guided positioning already you have seen, but then when we are doing it by ultrasound, so what we are doing, that in X-ray guided positioning also, this ultrasound positioning will help you to understand the location. So here, first thing, as I told you, that here there is two lines, M1 and M2. Okay, this M1 and M2. So first let us understand what is M1 and M2. Okay, so here this line from angle of the mandible to styloid process, this is M1. Okay, if I make another line which is just like this, okay, just here this distance is 1.5 centimeters. Okay, this distance is 1.5 centimeter from this one to this one. So this one will be M2 and this one will be M1. This one is M1. Okay, upper one is M2. So here, if my ultrasound probe is like this, okay, at M2, then what should I see? I should see this side bone, anterior side bone of the mandible, and posterior side bone of the mastoid. Posterior side bone of the mastoid. Between these two, in this area, what we will see? Most superficially, of course, we will see the bone. Here, the bone is not there. So most superficially, bone will be like this, okay, in this area. And then after bone, we will see the vessels. Nerves we will not be able to see because these are very small nerves, but we will be seeing the internal carotid artery. Internal carotid artery, above that, this is the bone, and between them, there will be nerves. Okay, so this is the locational, I mean, how you should search. So here, let us see. Now you see and that this is the M2 positioning. So here, this one is M1 actually. This one is M1 and this one is M2. Here in this picture, we can understand this side is anterior and this side is posterior. This side is posterior. Okay, in this picture. So here also you can understand that in positioning where we will do. So this shadow, is not just the mandible shadow. This part is mandible, and this is what, this is the mastoid process. This is the mastoid process. So from M1 to M2, the thing remains same. So this anterior side, this is the mandible, and posterior side, this is the mastoid. And between them, these are the vessels. Okay, these are the vessels part. Which vessel? So here internal carotid artery is much bigger vessel. So you will see the internal carotid artery. And so I remove them. And here actually mastoid process. So this mastoid process is much not mastoid, styloid process. This styloid process is much easily seen. Okay, styloid process, just the, you can see the posteriorly hypoechoic shadow. Okay, the acoustic shadow you can see. So this is the mastoid process. So there are three bony structure. This is one bony structure. This is one bony structure. This is the styloid process bony structure. So these three bony structure you will see here also, and here also. So these three are styloid process. So you can understand, if this is styloid process and this is the vessel, then where is the nerve? Nerve is in between them. These two areas, these are the nerves area. They are the glossopharyngeal nerves are there. So injection should start from the anterior side, hit the this styloid process, and then go posteriorly for 1 centimeter deeper. You will slide posteriorly and go 1 centimeter deeper. Okay. Here actually this cannot be total mastoid process because mastoid process is not that big, but then this is just like mastoid process. Your needle will come from anterior side, just slide by this and go 1 centimeter deeper, and you will inject there. Here this is styloid, and here has to be the vessels. Okay. So this is the ultrasound guided needle positioning. And needle positioning, I mean, you will not be able to see by X-ray the position of the internal carotid artery. It remains similar. Between two bones, you will have to find the mastoid process. So this much only. So here you can see now. So in X-ray also. So this is the mandible, this part is mastoid, and this part is styloid. So under X-ray, it is the styloid which is very important. Under ultrasound also, styloid is important, but then internal carotid artery gives us some another important criteria. I mean, another important clue that where we should search. And another thing is, while entering the I mean needle, you must see that at what depth this carotid artery is there. Okay, so you should not, if you do not find the styloid process, you cannot go on going deeper and deeper. So you know at 2.5 centimeter only, or say even less actually, or 2.5 centimeter, this carotid artery is there. Okay, so or say, yeah, 2.5 centimeter, our carotid artery is there. So as soon as you enter up to say 2.3 centimeter, you must think that whether I am missing the bone or not. Okay. So this much only. So is there any question? 34. So if you do not have a question, I ask you some questions. Okay, let's see. Because today's class was very completely theoretical. So whether you heard or not, let me ask you. So one patient came to me one day, and she was like standing under a coconut tree, and coconut fell on her head. So after one month, or say 1.5 months, she started having headache, which is like short bouts of headache, seconds, like every day she will have 80 or 90 times of headache, and it comes and goes, electric shock like. Okay, so what is your diagnosis? Have you heard of this type of headache? Anyone? It comes and goes 80 to 90 times every day, and electric shock like for 1 second it stays. So it is a type of headache which is called
Secondary headache.
idiopathic. Which one?
Secondary.
No, it is not secondary. Secondary is different thing. Like secondary, you will do MRI and all, and you will see that if there is a cause or not. So this is also a primary headache, but this is called idiopathic stabbing headache. Okay, or ice pick headache. So this is the type of headache. Okay, I ask you another question. Like one person came to me and told that. It was a male person, around say 35 years old male, and he told that his headache stays for around say 20 minutes, 25 minutes. It is one-sided headache, always one-sided headache, 20-25 minutes, and minimum 6 times to 7 times every day he is getting that headache. Okay, it is one-sided 6 to 7 times a day, and 15 to 20 minutes headache. And it is when the headache comes, so he has nasal stuffiness, he has some lacrimation or watering from the eyes. So what type of
Cluster
headache?
headache.
Cluster headache.
Cluster headache.
Okay, this is cluster headache. Okay. So uh, another person came, and another patient actually, she came, she was a 14 years old girl. So she came saying that suddenly paresthesia of her hand starts, and with paresthesia, her one side of the body stops working. I mean, many times she was admitted in the hospital thinking that she has stroke. Okay, and then after few hours, CT scan also was done, CT, MRI, everything was done, and it was all normal. And after around 2-3 hours, or say even more, 12 hours also, sometimes 12 hours, sometimes 24 hours, she becomes all right completely. But whenever her many times, 3-4 times it happened that paresthesia starts, then headache starts, and then half side of body becomes paralyzed. So what is this?
Migraine.
Migraine with aura.
Migraine.
Migraine, but
Migraine
type?
with aura.
Migraine with aura.
Migraine with aura.
It is not aura. It is chronic hemiplegic migraine. This is called hemiplegic migraine. Remember, there is aura symptom. There is a what is aura symptom? Aura symptom duration is half an hour to 1 hour. It shows, of course, it has a neuro deficit. When headache starts, aura should stop. Okay, aura can be visual aura can be sensory aura can be motor aura. Everything is there, but aura is not for 12 hours or 24 hours. It has to go when the headache starts. So this is chronic hemiplegic migraine. So multiple different types of patients usually come. So another patient came. Okay, this is an old patient, 80 years old. 80 years old patient came, And he told me that it is very difficult to see. Suddenly he is feeling that his one eye is not working. I mean, his dimness of vision started or something like that. But he told that this is also problem, and this my headache is also problem. So he showed this area. It is a pulsatile type of headache. I could see the pulsations, and some EA is also there. I mean, his visual complaint is also there, and this was a pulsatile headache. I could see. So what can it be? He's a aged person, 70
Giant
years.
cell arteritis.
Yes, temporal arteritis or giant cell arteritis. So this is, I mean, this is an emergency. As soon as his eye symptoms are there, then the high dose steroid has to be started. Okay, 60 mg prednisolone or something like that. So at least you can send the patient to hospital setup for getting admitted also, because you cannot take that much risk. But this is an emergency. You cannot give low dose steroid, or you cannot wait for any investigation. Though, of course, it will be, people will say that, okay, biopsy is the main, temporal artery biopsy is the diagnostic thing, but the treatment has to be started, whether someone goes for biopsy or not. Okay, so headache is a very nice subject, and so headache, neuralgia, treatments nearly same, but diagnostic part is very nice. And this glossopharyngeal neuralgia also, Dr. Devjyoti was doing glossopharyngeal neuralgia treatment just few days back only under ultrasound. So, I mean, it has a very good success rate. Both the things, glossopharyngeal neuralgia and trigeminal neuralgia has very high success rate. And I mean, surgery is can be delayed, and we are doing many procedures post surgery failures. So this part you have to be very confident about this. Okay, then if no question from your side, then thank you. Good night. Okay.
Thank you, sir. Good night.
Thank you, sir. Good night.